Thanks so much. Happy to be here. And I have been looking forward to giving this talk to you all to hopefully, if you're suffering from nerve pain or you know somebody who's suffering from nerve-related pain, I'm hopeful that this talk will give you kind of an overhead view of the options that are available. And then we'll be gearing our talk towards the end, focusing on a procedure called targeted muscle re-innervation, which was really developed for patients who have had a major limb amputated and are suffering from pain as a result of that. So we'll begin talking about nerve pain in general, and we'll talk a little bit about something called phantom limb pain, which affects folks who have had a major limb amputated. Then we'll be talking about treatment strategies for nerve pain without the use of medicine or surgery. Then we'll be talking about general options for treatment of nerve pain with medicines. And then we'll focus in on my specialty, which is treatment with surgery, and specifically on the technique that we have currently available called targeted muscle reinnervation. So if you're having pain, a nerve is involved in general. And most of the time we're suffering from pain because something is telling our nerves that it's irritated, whether it's a sore muscle or arthritis or injuries. But sometimes the nerve itself can be irritated. And we call this neuropathy, or something is wrong with the nerve itself. And this can be due to a variety of reasons. It could be a pinched nerve. It could be an injured nerve, such as a cut with a knife, or you could develop after something like a large limb amputation, something called phantom limb pain, which is in its own form of neuropathy that we'll get into in a little bit. And when folks see me in the office for nerve-related pain, they're often describing symptoms like a burning sensation, electrical sensations, shooting pain. They could have numbness or a throbbing sensation and tingling. And then sometimes folks can have a lot of sensitivity in the area where the nerve normally supplies. So on the right, this is a general diagram of different nerves affecting the hand and different nerves in the leg and the territory that they service. So if you think about like a cell phone tower and what it kind of is in charge of, you can see that over on the right side. And sometimes when you're running your finger along somebody with neuropathy in the zone where that nerve services, it can cause a lot of discomfort, and that has an anatomic reason to it. And then some folks experience phantom limb pain, which is a very specific problem, but it's basically the general sensation that the limb that the person used to have is no longer there, but they feel like it's still there. And that can be uncomfortable as an idea, and it can be very painful for others. So the causes of nerve pain, like we had mentioned, sometimes folks can experience a pinched nerve and that causes nerve-related pain. And we think of the most common causes or the most common types of pinched nerves, namely carpal tunnel syndrome, which is a pinched nerve at the wrist level. And then you can have cubital tunnel syndrome, which is a pinched nerve at the elbow level. And those types of pinchings can cause all those symptoms we talked about. If you have a major injury like a cut with a kitchen knife or a crush injury from, let's say, a car accident, you can also have nerve-related pain that's related to an injury to the nerve itself that's causing issues. And even if you have just inflammation in the tissues around a nerve, sometimes that can be enough to set the nerve off and cause some irritation. Sometimes folks can have medical problems with the nerves themselves. And when we think about this, we think about the common culprits, including vitamin deficiencies, autoimmune diseases. Viruses can cause nerve-related pain. We think frequently of shingles, which can be extremely painful and is related to the nerves. Diabetes and alcoholism can cause this sort of pain. And then sometimes, unfortunately, we just don't have a real underlying cause for the nerve pain to develop. And this becomes frustrating because when we don't know what the cause is, we have a harder time figuring out a way to appropriately treat it. But this is kind of generally what we think about as we're trying to piece together the reason people are having nerve pain. Phantom limb pain, like I mentioned before, is this phenomenon that we see in folks who have undergone a major limb amputation, an arm or a leg. When people are normally thinking about pain after an amputation, we're usually thinking about pain at the level of their limb as it currently is. So somewhere in the residual limb. But folks who are experiencing phantom pain may have a sensation that their pain is existing, but it's in the limb that is no longer there. So sometimes patients can describe to me that they feel like their hand is still gripping on to something, even though that hand is no longer there. And that can be really uncomfortable for folks. And phantom limb pain is very common. So folks who have undergone a major limb amputation, 45 to 85% of them will develop some sort of phantom limb pain. And of them, 5 to 10% will have some persistent phantom limb pain, which can certainly be very aggravating. And what we know about major limb amputations is they are generally painful compared to other major procedures. And in fact, 1 in 5 folks who have undergone a major limb amputation, an arm or a leg, will be on opioids or narcotic pain medication for a long period of time. And that is a very high number of folks compared to other major procedures that you could undergo where you don't have that major risk. So there's something about having a limb gone that is painful for many people. And as surgeons and physicians, this has been one major charge of ours, is trying to figure out why and figuring out ways to help with that. So diving into treatments, you can think of things as treatment without surgery or medicine, treatment with medicine, and then treatment with surgery. So let's start without the use of medicine or surgery. And when we're trying to offer treatment in this way, we have a few goals in mind. The first is to try to keep the nerve in a good position, a healthy position that's not causing it to get pinched, not sacrificing blood flow to the nerve. And that can be achieved in a variety of ways. We try to give the nerve an opportunity to recover on its own with these methods. And we're trying to prevent repeated trauma to the nerve. Sometimes when folks are experiencing nerve pain that's resulting in the nerves being extremely sensitive, we'll try to re-educate the nerve. And that may mean giving it more stimulation to try to give it a sense that, okay, this is the new normal, and it's okay to relax now from being irritated a little while ago. And then many of our treatments are focused on distracting the nerve so that we can hopefully decrease pain that our patients are experiencing. So what this involves is making use of something called the gate control theory. So what gate control theory basically assumes is that the information in the nerve that travels from a tissue like your fingertips or your foot, they travel in this information highway, much like your internet does at home, all the way to your brain. And it gives your brain a variety of pockets of information that can include the sensation of pain, but it can also include the sensation of vibration or heat or where your finger is in space. And what we believe is that, there's only so much information that can get to the brain at any single moment. And if you're focused on the pain, you will experience a lot of pain. But if we're able to distract that pain by giving you something else to sense, for example, feeling a vibration or feeling a sensation of heat, this will kind of clog up the system and prevent you from experiencing the sharp pain that uses the same anatomic pathways to get to your brain. And that way we can kind of drown out that signal this way. And so a lot of our non-medical ways of managing pain are focused on making use of this pathway. So when we're thinking about treatments without medicine or surgery, we're often employing the help of a therapist, either a physical therapist or a hand therapist, to help us with this. They may institute some splinting to keep the nerve in a healthy position that's going to improve blood supply to the nerve. We may introduce some exercise or stretching to, again, do two things. Number one, get the nerve moving and in a better position from that standpoint, but also to introduce some more sensations to the area to hopefully drown out any pain sensation that could be experienced. There are topical ointments that are available. So if you think about stuff like Icy Hot or Bengay, capsaicin is a stronger, potent variety of this. And they work primarily at distracting the pain by providing a heat source. And that can be very effective for many people. There are patients of mine who describe use of acupuncture or a TENS unit, which is a device depicted on the upper right hand over here. And they similarly are methods of distracting the pain. Acupuncture works in a different way, but it's not my field of expertise. TENS units, on the other hand, do use an electrical current as a means of kind of distracting the pain by stimulating the muscles nearby. There's also something called mirror therapy, which is specifically for folks who have major limb loss typically. But what this involves is basically using a device called a mirror box, which is depicted over here on the right bottom. And what this is intended to do is allow the person using it to cast an image of their unaffected limb over onto the location of their affected limb. And this creates this false sense that the limb is still there. And you can do exercises using the mirror box, and your eyes see this and transmit a signal to your brain that makes it think that that limb is still there. And performing exercises with the mirror box using mirror therapy can sometimes help alleviate a lot of pain that people are experiencing, because their brain also changes after an amputation, and this helps kind of unchange those pathways or make them more helpful for people. It's one of those things that is not completely understood, but it certainly does help a number of folks. So treatment with medicine is often guided by our patient's primary care physician, a pain specialist, which may be anesthesia trained or have some other form of baseline training, or even a neurologist for certain types of nerve pain. And it's not something that is within my realm of expertise. But generally speaking, our options for treatment fall into categories of a variety of different medications. They can include anti-seizure medications like topiramate or Topamax. It can fall under medications that were essentially designed for nerve pain, like gabapentin, which we prescribe also on occasion, as it works pretty well and generally has very few side effects. And then opioids are always there, and certainly everyone is aware of the side effects they have associated with them. So we try our best to avoid the use of them in the long term. And then there is certainly a role for use of local anesthetics. So you're thinking about not Novocaine or lidocaine, and this can be given to folks in the form of a patch that goes over the painful area, or as injections that are performed in the office to help kind of reduce or temporarily give folks a break from the pain. And unfortunately, nothing works perfectly for everybody. So there's a little bit of trial and error, and everything has its own side effects. So it's a lot of balancing out the two and finding what works for people. Treatment with surgery is my specialty, and I'm going to plan to spend the rest of the talk talking about treatment with surgery. And so as a plastic surgeon, oftentimes we're releasing pinched nerves. As a dual-birded hand surgeon, I frequently treat carpal tunnel syndrome, and that's the most common thing that gets pinched in the body nerve-wise. And that can be very effective for folks. We can repair nerves, and we are usually doing this in the setting of somebody coming to the emergency department who had, for example, a kitchen knife injury to a nerve that's causing them pain because now you have a raw nerve end, and we can repair that in the operating room using a variety of techniques. And then we have the option of targeted muscle reinnervation, which we'll get into later. And this is the most sophisticated thing that we have to offer as a specialty for nerve-related pain. And then there are things that other providers can perform as well. So, for nerve pain, some folks receive a benefit from something called a spinal cord stimulator, which is often implanted by a neurosurgeon or a spine surgeon. And it's a device that's meant to, again, help with nerve-related pain or neuropathy through the use of this device that transmits the signal directly to the spinal cord. And that is not my area of expertise, but that is certainly an option. And I've referred folks for it when we don't have very many other options. And then similarly, our anesthesia interventional pain colleagues do have interventions that they can offer as well, mostly aimed at dulling the nerve through injections that they can do in the office as well. So, focusing on targeted muscle reinnervation, what exactly is that? And so we'll have to take a step back and think about the anatomy of a nerve. And so if we look on the left-hand side, this is what a nerve looks like on an individual cell level. And so if you took a very high-powered microscope, you'd be able to see the cell body, which is over here, that looks like a little bit of a star. And then each one of these will send out a little nerve tube called an axon that goes all the way to receive signals from whatever tissue it's supposed to be interacting with. And what can happen after an injury here is there's a sophisticated process in which the body gets rid of anything that's in the way between the nerve and where it's supposed to go. And then it undergoes this process of regrowth, where the nerve sends another sprout all the way down to where it's supposed to end up. And on a larger level, like as a surgeon, this is more of what I see. The nerve itself looks like a big noodle. It looks like a yellow tube, and it has some blood vessels attached to it. And if you cut that tube in half, you see a bunch of smaller tubes. And each one of these is containing, thousands of these little tubes within each one of them. And what we try to do in surgery when a nerve gets cut is we try to put the nerve ends together neatly so that the tube is connected in a way that allows these little nerve sprouts to go uninterrupted towards where it's supposed to go. If it doesn't do that, it will end up forming a nerve ball or a scar ball at the end of the nerve because it doesn't know where it's supposed to go. And that is called a neuroma. And neuromas can be very painful for people. So here again is a diagram of a nerve. So as I said, it looks like a little noodle, even when we look at it in surgery. And here is an example of somebody who may have had a major limb amputated, and they end up with this nerve ball at the end of the nerve, or a neuroma. And these can be very painful, as I mentioned. And what we have done historically, more than 10 years ago, to try to treat these painful nerve balls is we would cut it somewhere further up, closer to the body, and we would take that free, fresh cut nerve end and put it into a muscle nearby or somewhere away from the skin where it was causing discomfort for people. And what we learned is that this basically just ends up turning into another nerve ball, but it just ends up in the muscle or somewhere else. And sometimes that's effective enough, and sometimes that can still be painful. So what we as a specialty have aimed to do currently is try to prevent this nerve ball from forming. And the way that we can do that is by giving the nerve a place to go and a tissue to interact with, and connecting it to another nerve to allow those nerve sprouts to travel down neatly and orderly towards where it's supposed to go. And so on the right is depicted the same situation, but instead of cutting the nerve and burying it in a muscle, we find another nerve that goes directly into that same muscle, and we connect those two nerves together. This way, the nerve starts to grow and then starts to interact with the muscle and starts to share information with the muscle. And that is what targeted muscle reinnervation is. When it was first developed more than 10 years ago, it was originally designed to help us develop better, more sophisticated robotic limbs. So for prosthesis, specifically for the upper limb after a major amputation. And what we learned after doing these procedures for this purpose is that people had less pain. And we believed initially it was just because we were treating neuromas. And then we started to realize that it was actually treating some of the neuropathic pain, such as phantom limb pain, that people can experience as well. So this is one of the major studies that we often refer to. This was a randomized trial done on veterans looking at whether or not doing targeted muscle reinnervation was going to be better than doing the traditional treatment of cutting the nerve and burying it into a muscle nearby. And what we found from the study is that 7 out of 10 patients who had targeted muscle reinnervation, so connecting nerve to another nerve nearby, had either no symptoms of phantom limb pain or very mild symptoms. This is compared to 4 out of 10 patients who had no symptoms of phantom limb or mild symptoms. So it's not 100% effective, but it's certainly better than what we had previously. And that's why we've been offering it to folks for this purpose as kind of the best option we currently have with our current technology. And so if somebody is coming to see me for this procedure to see if they're a candidate and see if it's a good choice for them, the first thing we talk about is whether or not their pain's been managed by non-surgical means. So have we been on the medications that would be appropriate for this? Has it been effective in any way? Then the next conversation we have is about their medical problems to make sure that those medical problems are adequately managed so that the risks of surgery are as low as possible, and that the ability for the body to heal from surgery is as good as we can make it beforehand. And then finally, and this is usually figured out before people even see me, but we try to make sure that this is the cause of their pain and it's nothing else. So some of the problems that folks who have had a major amputation suffer from is bone spur development at the edge of the bone that had been cut. Sometimes folks can experience just irritation from the prosthetic due to some extra tissue in the area or some other issues. But if we've kind of ruled all those things out and we think this is nerve related, then I generally think that people are a good candidate for surgery. And so during surgery, the task that we have is pretty cut and dry. Essentially, we're trying to find the problem nerve. Then we find a nerve that goes that is nearby, that goes to a muscle that is still functioning in the limb. And then we cut both of the nerve ends and then we connect them together. So diagrammatically, this is somebody who had a below knee amputation before. And there are a couple different options that we have for this. One option is to just make a cut in the back of the calf area where the nerves typically are. And the nerve that provides you sensation to the bottom of your foot is found, and we cut that nerve and connect it to a nerve that goes to one of the calf muscles and allow that to heal together. And so after surgery, usually folks stay in the hospital at least one night just to make sure that their pain is under control. And then what we can expect is usually the skin is healed in about 2 weeks. And that's when folks who are using a prosthesis could go back to wearing a prosthesis. And then what I warn patients about is that nerves take a long time to heal. They regrow from the area where they're cut to the area where they're trying to get it to end up at over the course of an inch per month after the first month of surgery. So if we keep that distance very close together, it may only take about 3 months. But if it's longer than that, it may take longer than that. And I've experienced a number of different outcomes in the short period of time. I've had some patients who had immediate pain relief following surgery, which is always wonderful to see. And then I've had patients who have had temporarily worsened pain, which can last until the nerve ends up where it's supposed to go. And that can be anywhere between 3 and 9 months after surgery. And so the major points that I'd like to leave with are that, unfortunately, nothing works perfectly. So if you read the data from that paper that I shared earlier, you can read it a different way and say 3 out of 10 patients still had phantom limb pain. And so, this is the best option that we currently have, or the most sophisticated option, but it's not going to be the end of the story, because we still have some folks that are still suffering from pain. It's also possible that we do the procedure and you can have a reduced number of pain medications, but you may still have some pain that needs to be treated with medication. And the upside of doing this surgery, additionally, is that it may set you up for the use of a robotic prosthetic in the future. So, it seems like every year there's a new advancement in technology, and that goes the same with prosthetic devices. And it's been very exciting to look at what's being developed and what's out there. And this is hopefully something that's going to set people up for having access to those devices as well. So with that, I'm open for any and all questions that you may have. At the bottom here is a paper we recently published on our technique done at Baystate for a patient who had an amputation above the knee and how we approach that surgery. And there are medical photographs in there if you're at all curious about that. It's widely available on the internet. You just need to Google it and you'll find it. But I didn't want to share it in this topic because I figured it may not be enjoyable for everybody to look at. So you're welcome to do that on your own.
Thank you, Dr. Naram. That was a great talk. You covered it really well, and I applaud you. Thank you. We already have a few questions in the Q&A box, but we invite the audience to share any questions that you may have on the subject with Dr. Naram. So the first one is, what are primary causes of limb loss that you see?
Yeah, so oftentimes it's related, in my practice, I often see it related to infections or poor blood flow issues, so peripheral vascular disease. And then we see it for traumatic reasons as well. That's very common. I can see all the questions here.
Oh, very good. Okay.
So, yeah, I'm happy to read them out loud.
If you don't mind repeating them, that would be wonderful. Please go ahead.
The other question is, how many TMRs do you perform annually? So I've only been here 3 years, or 2 years, I should say, and I've done 3 so far. The techniques are very much the same as what we do for treating paralysis with nerve surgery. So from a technical standpoint, it's something that we're certainly very used to, but it's one of those things that we're getting the word out and we're having more patients see us for this problem. But that's a great question. How does cutting the second nerve not cause another neuroma? That's a fantastic question. We're still unsure as to why, but that's something that has been studied, and it's very interesting that that just doesn't seem to be the case. And my general assumption for that is it does form a neuroma, but because we're cutting a nerve that goes to a muscle and not to one that provides sensation to the skin or have other effects to it, it may just not cause that much of a problem than having a big neuroma related to a major nerve that gives you, for example, sensation to your foot. That's a great question. Are there not multiple nerve endings that need to be addressed, or just one? There are multiple nerves. So depending on where the amputation level is, we may be going after 3 or 4 or 5 different nerves. And the way I focus it in seeing patients in their office is trying to figure out where on the limb it's most painful, and then working with all the nerves in the area and trying to find something better for them all to do. Another question is, do you have any more information on the spinal cord stimulator? I don't. I would refer you to our neurosurgeons at Baystate, and I think they would have the most information for you. If you look at brochures from various medical device companies, they all seem to have a different spinal cord stimulator, and it would be worthwhile to look into those things. I recently had a relative who had one implanted for similar type of pain, and the process has been somewhat enlightening in that there are lots of options, but unfortunately I don't have too much more information to give you, as it's just not something that I do in my practice. Would you use the technique on patients that have nerve pain that are not related to it? Yes, so that's a great question. In certain circumstances, we use the same technique to address nerve damage even if you have not had an amputation, but it's a very specific circumstance. So the last thing we want to do is downgrade somebody's function by sacrificing a nerve that goes to a muscle and provides function just to get rid of pain. But if you had an injury or chronic irritation to a nerve and it's just become a big nuisance for you, there are techniques that we have to use what we know about targeted missile reinnervation to try to treat that sort of pain. So that's a great question. And the answer is yes, we can do it, but it's in very specific circumstances. A cancer patient, hi, thank you. I will say I'm not an amputee, but a cancer patient with severe neuropathy in my left foot from chemo. I've been consistent with acupuncture and TENS machine, no pain meds. Can the surgery benefit me? Yeah, so this is one of those tough situations related to the question above, which is, if you're not an amputee, will the surgery benefit me? And currently, we don't have any information on this for this problem in particular. So at this time, I would say that you're not a candidate for this. But that being said, as we learn more about this information, about this procedure from the various centers in the country that are doing it, that may change. But at this time, I don't think that this is a good choice for you. How is a neuroma from an injury detected? So oftentimes, what people will describe to me is when you tap in one spot, you're feeling a jolt of electric sensation that's running up the arm. And that's most commonly the symptom that we have. There are some folks who get an MRI or some other ultrasound that shows the nerve turning into a neuroma at the end. And that can be very helpful sometimes, but oftentimes it's just the symptoms and the story. So if somebody tells me that they were cleaning the dishes and they cut their finger, and ever since then, there's a part of their finger that whenever we tap it, it buzzes, that tells me that there's a neuroma there, and we can certainly try to fix that. Is there PT or other therapies post-surgery? If so, how often and how long does that typically last? Typically, no. So usually if we're doing this surgery in somebody who's had a major limb amputated, they're engaged in some sort of therapy anyway. And they basically resume that sort of therapy. And if there is some difficulty with motion with some of the joints that are remaining, certainly we can address that. But there's no specific thing that we need to do in order to encourage the nerves to go to the right direction. What we will see, though, is that once the nerves have found where they're supposed to go, folks will be able to show me that their muscles twitch when they're thinking about moving their foot in a certain way, which wasn't occurring before surgery. And that's evidence that the nerve has found the muscle that it's supposed to go. And if we're using those extra muscle twitches to communicate with a robotic prosthetic, then sometimes therapy is helpful, because then we can start to work on making those signals stronger so that the robotic prosthesis can read those things better. But for somebody, for example, who lost their leg below the knee, and there isn't really a major robotic prosthesis that's designed for treatment of that, or to help somebody with that, usually therapy is not required. Just going back to the prosthetist to help deal with swelling and resuming the normal therapy that you've been doing before then, that's usually plenty. And I had a friend with shingles, which has caused agony to her back. Any suggestions? The things that I would recommend are pretty much medical management. There's not really a surgical way of helping with shingles that I'm aware of currently, or that has been studied currently. Some of the over-the-counter remedies, including capsaicin, can be very helpful for shingles. But I would have her talk to her primary care doctor about some medical ways of dealing with that pain. Sometimes those Novocaine patches, lidocaine patches can be helpful, but unfortunately, I don't have much to add from a surgery standpoint. Can this be done no matter how long you've been out without limb? Yes, it can. So with phantom limb, sometimes folks can develop phantom limb type symptoms a year after the amputation. And there's no time limit in which we can no longer do this, because the nerves that we connect the blind ended nerve to, so the nerve that is causing a problem, when we connect that to a new nerve that goes to a muscle, we're using a muscle that already works. So we can do that at any time. That there's no time limit on that. I realize this is not a major focus of the discussion. However, I have post-herpetic neuropathy in the left forearm and occasionally goes up to my shoulder. I'm taking pregabalin prescribed by a neurologist, but it doesn't seem to prevent the occasional acute pain. What should be my next steps? That's a great discussion to have with your neurologist. So this is another one of those situations where if you're having neuropathy that's related to a viral illness and inflammation, I don't have a lot of good surgical options for you at this time. It's something that we're constantly studying and seeing how much of our surgical nerve techniques can be applied to these medical problems related to the nerve. But right now, I wouldn't suggest doing any sort of nerve surgery for that. Depending on which nerve is involved, it seems like your forearm, it's probably a skin related nerve. And there's not very much that I could recommend for that. That wouldn't completely, remove sensation in that area, where the nerve is providing service to. Excuse me. The long and the short of it is basically, unfortunately, I don't have any surgical options for you. But I think your neurologist would appreciate knowing that, because potentially they could go up on the dose of the medication that you're currently on. I have peripheral neuropathy to one toe after an injury. An ankle foot specialist wants to perform surgery to a knuckle of the toe to remedy the burning throbbing. Your thoughts on this? It's unclear what you're referring to. It may be something called a Wharton's neuroma. And foot and ankle doctors treat this very commonly. So I think that it sounds like your foot and ankle surgeon may have a good handle of what's going on, and I think that's a very reasonable thing to go after. And can TMR be used for recurring neck issues? I am not familiar with it being used in this sense. This is not really meant for treatment of spinal cord related or nerve root related pain necessarily. And so if it's neck pain related to a cut nerve in the area that is just free and causing disruption, then it could be used for that, but not for neck pain or spinal cord related pain. That's related to maybe something like a pinched disc in the nerve in the neck, or arthritis in the neck. This is not something that would be worthwhile for that, or not something that's been studied for that problem.
Well, thank you. That looks like the end of the questions. We'll just give folks another minute.
Those are great questions, and again, I'm happy to answer everything to the limits of my knowledge here. And for that matter, the specialty knowledge, because one thing that I think was apparent during the pandemic, and is certainly true here, is science is constantly evolving. We're constantly learning new things, and my hope for this talk was just to give you what we have now, and in a decade it may be very different, or maybe even more sophisticated than it is now. But this is unfortunately or fortunately what we got for the time being.
Well, I applaud you for keeping up with the technology. Thank you for your time, Doctor. Really
happy to be here.
Great talk. And an attendee says, thank you, very informative. And I would agree. Have a great night. Thank you for your time and expertise. And thank you to the audience.
Yeah. Great. Thank you so much. And thank you very much for the book recommendation. I'll look into that.
Excellent.
All right. Take care.
Thanks.